Welcome to Policy Connecting Communities. I'm Anna Bullet, your host. In today's episode, we cover mental health in Minnesota, one of the most common health conditions in the United States. It's an issue that deserves to be in the spotlight. I am pleased to interview amazing, talented, impactful, culturally informative, and insightful leaders who made this episode possible. There's something for everyone, whether you are a student, parent, provider, practitioner, policymaker, or engaged citizen. Or maybe you're looking to advance your cultural responsive skills, or you're looking for ways to connect with the communities, or simply looking for ways to make a difference. Maybe you're looking to shape future policies and improve outcome for individuals struggling with mental health conditions. With us today are Sue Abderholden, Executive Director for the National Alliance of Mental Health in Minnesota, Brendan Jones, Consultant and Executive Director for Minnesota Association of Children's Mental Health, Chad Cartier, Director of Psychotherapy for Aris Clinic, Lisa Wong, Senior Community Health Specialist for Washington County Public Health and Environment, and Nimo Ali, Clinical Social Worker and Therapist, as well as owner of Optimum Behavioral Solutions. Thank you for joining us today.
Thanks for having us.
Yes, thank you.
Yeah. In Minnesota, what are we learning from this existing data, such as the Minnesota Student Survey? What recent trends have you seen that concerns you considerably or surprised you? And any of you can start this question.
My concerns are really with girls. So we know that the data on girls is worse than the data on boys as children who identify that way. So in 2016, it was 27% of girls actually were looking at long-term mental health issues, and that went up in 2022 to 37%. We also know that girls are experiencing higher rates of anxiety, depression, and suicide attempts. And I think the other one that concerned me was related to suicidal ideation that was very high among our Native American youth and youth who had identified with multiple races. And so our kids are not doing well.
Yeah, absolutely. I would agree with that. I think another thing that is pretty stark, and I don't think we always associate this with mental health, is a lot of our kids feel like they don't have things to do. There's a lot of inaction. And the survey proved that where, there was either answers of they're not interested in after school activities or social clubs, or they just are too busy doing, working their own jobs or doing homework to even engage socially. And even if you compound that with how the pandemic has played a role in the lives of young people, and then also just technology and how devices play a role in young people. A lot of young people are just not socializing in ways that they were 10, 15, 20 years ago. And I do think that that's playing a huge role in the mental and emotional health of our youth.
And I would have to agree with what both of them said, especially since COVID started. I did notice that a lot of kids have been struggling more and have just been really struggling with both substance use and mental health issues. And it makes it even harder to get them services when they are very limited outpatient services, inpatient services out there for those kiddos.
These are great points. What have you found, Lisa and Chad?
Yeah, some of the data that we see statewide is certainly, especially when we focus on the Minnesota Student Survey, there's over 100,000 kids that take that generally throughout the state. And so it's a big source of information for us, and it's been around since 1989. So we do get some pretty good data from that over time. And, as you had said, it is certainly still an issue, partly because the pandemic has exacerbated mental health so much, particularly, especially our young people, and that's no exception here in Minnesota.
I couldn't agree more. I can't cite chapter and verse all of the data, but anecdotally from our clinic, I can tell you that certainly there's been an increase, and COVID certainly exacerbated a lot of those issues that we were seeing pre-COVID. So a lot of school refusal, kids who are having a hard time moving out of the house, making connection back in school, getting caught back up, reestablishing routines, et cetera, et cetera.
Lisa, are there data within Washington County? It's one of the larger counties in Minnesota, and it's one of the growing counties in Minnesota. Are there things that come into your radar, or are there things that Washington County is learning from community partners like hospitals and schools that is, again, surprising or concerned when it comes to mental health?
One of the ways in which we kind of get a pulse on this is through our work in assessment. As somebody who looks at data often, we're looking at data and collecting data through something we call the community health assessment. And that's something that we're required to do every 3 to 5 years. And our partners at the health systems are also required by state statute to do some assessments. And so we're collaborating at this moment to get those reports compiled and learn a lot more. But part of the work that we're doing is getting a better pulse on what's going on in community, and that's through community focus groups or community conversations. And historically, our county has not focused as much on culturally specific populations, which is continuing to grow and grow and grow in Washington County, and that's certainly going to be the trajectory. So with that, we've found some challenges seeing culturally appropriate resources available for the various populations that live in Washington County, from our East African communities to our West African communities, certainly impacting a lot of residents in Washington County.
One of the questions I want to ask you is mental health treatable?
100%.
Yeah, definitely.
Absolutely.
Absolutely. You can make progress on that.
Yes, it is 100% treatable. However, I think getting more individualized treatment when you are getting therapy or medication management is so important. However, one treatment that might work for one person may not work for another one. I think going in with an open mind, just looking into evidence based when you are treating your clients, and just using the most recent research is so extremely important. But yeah, I think, yeah, it's definitely treatable. It's just a matter of individualizing that treatment plan and working collaboratively with that individual to make sure that that's what's going to work for them or what might work for them.
Yeah, I would agree with that. I would also say that I think we need to normalize that healthy behaviors lead to healthy emotional and mental well-being. I think it's very easy in our culture today to focus on the things that bring us down and to hyper focus on things that are extreme mental health cases and situations. But people go through things all the time, every day, and having just healthy habits is something that can help treat mental illness and mental health as well. Not saying that it's the only thing, but I think that having more of a promotion or just a normalization of just doing things to stay engaged and to stay and to stay well, I think will be helpful.
And I think I would just add that, treatment is effective if you can access it. And access right now is just a huge issue. We know that our school linked mental health programs are really pretty effective because we eliminate barriers to access. If you think about how difficult it might be for a parent to get off work, go pick their child up at school, bring them to a therapist, bring them back, go back to work, that can take, especially if you don't have a car, and if you're in rural Minnesota, that can take hours. And it's really hard for families to take off of work once a week to bring your child to therapy. So, making sure that we bring services to where children already are, I think helps increase that access.
Yeah, and then I just wanted to add that when we're looking at cultural considerations, in a lot of minority cultures or marginalized communities, mental health is so stigmatized. It's very difficult for people to accept or to even mention that they are struggling with mental health or substance use issues, and it makes it that much more difficult for them to actually get the services they need because of the shame and the guilt that comes with that. I think, and it's so important for them to get treatment. However, I think there needs to be a lot of work done when it comes to like educating people about mental health issues, the services that are available, and it's okay to seek help. It's okay, just like how when you do have physical health conditions, you would go to your primary care physician. It's absolutely okay to go out and seek mental health services when you are struggling.
I have a son who's struggling with mental health, and it started when he was in 10th grade. And we didn't talk about it due to mental health stigma in my family. We didn't talk about it. Even my own immediate siblings did not know the struggle that we were going through because my husband was not comfortable. So I didn't say anything to many people. And um, now it's been 6 years. Now I think I'm starting to feel comfortable to share, and I'm even like probably the first time I'm sharing in a public platform like this. And I've noticed that the few parents I spoke to, without realizing they have a child with disability or a mental health, as soon as I told them my son is struggling with severe, persistent mental health, they shared their story with me. And that was the most surprising thing to me, is that they actually told me they have a family member with struggling with mental health. How is mental health addressed in Washington County? What's included in your current system and support and services in the continuous of care, and what are some of those unmet needs that are not being addressed or underutilized, or we don't have the capacity yet?
I think, with Washington County, one of the services that we certainly provide is the crisis response unit. That's our mobile crisis. And what folks can do, and this is available for both adults and children. And basically, they contact the county, and I'll provide the number. And this could be for a range of interventions or crises people may be having. It could be, at school, like really struggling with getting to school, for example. Like you can get them on the phone, they can help coach you, and if necessary, they may even come out to you in person. So they can help with something as small as that to someone who is having really severe symptoms, and they can help to come and help provide referrals or make sure that they're getting care right away.
Yeah, if it's okay to, appreciate you mentioning that, Lisa. We make use of crisis response teams a lot, and not all counties are created equally. In that there's quite a bit of variation from county to county, and what those crisis teams look. And I'm sure they're all working terribly hard. Washington County, I think, is responsive and does a pretty good job. But that's that intermediary point between a kid making contact with a police department, which is the next step, or immediately being taken into the ER, where they're going to wait who knows how many hours, because they're very busy. And oftentimes by then, the whole process is de-escalated and they're sent home after about an 8-hour ordeal. So for a clinic like ours, where we have up to 60 kids in our intensive outpatient day treatment program, we get a lot of families and kids who come in who are in crisis. And it's not out of the question that there are going to be a night or two like that where there is crisis at home. And it's great to have a service where some mental health professionals can come and de-escalate, get a plan together, and avoid having to do that next step, which is to go to the ER to call the police. So it's a really important resource.
Chad, I've noticed that you're located in Woodbury and your specialties includes children struggling with trauma, depression, and anxiety. You offer a day treatment program for ages 8 to 18, as well as outpatient services for all children. What data informs your area of specialty as an unmet need or area of need?
Sure. We find having after hours crisis response is a huge resource. And I think that, as I said, Washington County, I think, is doing a pretty good job, but not all the counties that our kids are coming from can that be a reliable service. Sometimes there's, an hour, 2 hour, 3 hour lag time before they can make contact. Beyond that, inpatient hospitalization, that is a frequent. There are no beds available in the Twin Cities area. And so you have kids who are in crisis and distress who sit in an emergency room. And the number of young people we're seeing with remarkable aggressive behavior, so physical aggression at home, physical aggression with others, and programs are increasingly finding it difficult to work with that. And families and kids are having a hard time getting services that would otherwise potentially be a good fit, but the aggressive behavior is an exclusionary factor, and they become hot potatoes. Part of that is what you need to be, the resources that you need to be able to manage that. The other part of that is it's very high burnout and turnover for staff who might not have all the training and can only hang in there so long doing that kind of work. And so we find a lot of parents who desperately want help and want to turn the corner and develop some better skills when aggressive stuff's in the picture, but can't find a program that will accept them. And then autism spectrum, that's a diagnosis that has increased significantly over the last maybe 10, 20 years. And that runs a spectrum of those that would have met criteria for the old Asperger's, which is no longer formally in the DSM, to those with more remarkable autism spectrum and need more specialty services. But we see a ton of kids who need some kind of unique special support with staff who understand autism spectrum, and yet there aren't a lot of programs. And sometimes it's like fitting the square peg in the round hole to have a kid who has some unique needs who could really respond well to a holistic program environment, but they don't have staff or a program that's set up to meet their needs. And so those parents and kids are often left with like, where do we go? So those are the areas I see we need to improve some resources.
Yeah, thank you. And Chad mentioned about the DSM. The DSM is the Diagnostic and Statistical Manual of Mental Health Disorder that psychologists and social workers use to when they're doing assessment for children and adults. And Sue, can we talk a little bit about like sort of the spectrum of mental health illnesses? I know it helps with the continuum of care. And what are some of those causes that is being associated with mental health?
Sure. I think that we forget, just like health, right? You have good mental health and you have good health, bad health, and then a whole lot of things in between. And the same is true for mental health, right? So you have someone who has great mental health, they're able to participate in their community, do well in school or work or whatever. And then you have some people who might be kind of struggling a little bit. And then you have people who have very serious mental illness where it's really disrupting their life. And we need to pay attention to that entire spectrum. And as Brandon mentioned earlier, we want folks to focus on keeping their mental health good. But then there are some things that you just can't, you can do all the walking and, eating well and all those kinds of things. And still you develop a serious mental illness. And certainly genetics play a role, trauma plays a role. All of those things can really impact your mental health. COVID certainly, has played a role as well. And the importance, I think, is that early identification, so that you don't have to wait till someone has a very serious mental health condition. I wanted to mention about, so it's 2 years ago, we had a bunch of students actually come to the Capitol from diverse backgrounds who wanted to be able to access mental health care, including at their schools, without parental permission. And part of it was because their family didn't really believe in mental illness, didn't believe in mental health treatment, had, kind of the negative attitudes about it. And it did pass. So 16-year-olds, 17-year-olds can actually now consent to outpatient mental health treatment. But it was from those students from culturally diverse communities who really made that happen. And I just thought that was really kind of interesting.
That's amazing. That's really remarkable. And I think it speaks a little bit about the mental health stigma and culture. But from a cultural perspective, how do you think mental health is perceived in the communities that you work with, or even from your own culture?
From my experience, culture has played a role in mental health and mental health treatment a little different depending on the culture. I think generations also play a role in this as well, as you see different generations have different approaches towards mental health. As an African American person, as a Black person, one of the things that I've learned about my own culture and dealing with my own mental health is that we've learned ways to cope and build our mental health struggle into our cultural identity. So a lot of times, we will see the trauma or the intergenerational or historical trauma things that we've gone through as almost badges of honor due to our ability to be resilient. And I think that has been a positive on one end and a negative on another, because there are people who expect for bad things to show up and to take place, and that, and then they minimize the anxiety they may have, or they minimize the depressive symptoms they may have, or other further mental health systems or symptoms, and they'll call those things like, oh, you'll be fine, or oh, that person's just acting a little crazy, or something. They'll use these terms that really minimize the actual condition that the individual's going in, and that can be a struggle. I know for myself, that was a struggle for me as an adolescent. I'm pretty sure I could, if I was to see a mental health professional, I would have been diagnosed with clinical depression. But since Brandon had good grades in school and Brandon played football, no one ever asked me how I was doing. No one ever questioned anything. and I would just kind of floated under the radar, even though I was miserable every day doing all the things that I was doing. But in my culture, I was a standout young person because I played sports and I got good grades. So everybody thought I was fine when I really wasn't.
Yeah, I'll just reiterate what Brendan said. In my Somali culture, as long as you're doing well, you're doing good in schools. Mental health is not really something that we talk about in our households. It's not something people that are pretty open about. And if kiddos come to their parents and they talk to them about like things that are happening at school, bullying, peer pressure, things that are affecting their mental health, sometimes it's dismissed. They're just told to get it together. Parents are not quick to actually seek help for those kids. And because of the stigma surrounding mental health, like in my culture, if you have mental health issues, I know that people are becoming more educated and more open-minded at this point, but previously you're just seen as crazy. And you don't get the help you need right away. And like Sue mentioned earlier, early interventions are extremely important. And when kids are not getting the help they need right away, they do tend to struggle more as they get older. I work with a lot of young adults from my community right now that are truly struggling with the transitions of becoming an adult, figuring out life, have been struggling with depression and anxiety almost their entire lives, and have not really gotten the help they need. So I think, again, because of that stigma and the shame that surrounds mental health in my community, is just a lot harder for kids to get the help they need, and they just tend to struggle more.
Can I add one more thing? Nemo just highlighted something I want to highlight a little bit more. I think in a lot of ethnic minority groups, a lot of times what happens is that there's a fear, and that's what keeps us from going and seeking services. That systems may get involved, and your children may be taken away, your job may be jeopardized, or your housing may be jeopardized. And people end up having these compound mental health issues and concerns because of the delayment in even going into receiving treatment. And that is a big issue. And when I was practicing clinically, there were so many clients that I would have that they were going through their situations for years before they actually sought out therapy. And it does make the work a lot more challenging because there's so many things to kind of comb through and unpack and even address, that sometimes just that delay in services does make a big difference. And there's a lot of shame around that as well. Go for it.
One thing that I've observed just having conversation in community and with youth is, especially youth of color, it comes down to a lot of bullying in school. And it's not just like in-person bullying, it's also cyberbullying. And a lot of it can be around racism or some sort of discrimination. And so when I was in conversation with youth asking about, talking about mental health, when we got to bullying and talking about, their identity, everyone really got engaged. So I felt a lot of anxiety and stress in that particular area from our youth.
We certainly have a diverse group of kids that come through our program, from the inner core of the metro to rural Caucasian Western Wisconsin. And so I don't want to take something that is anecdotal to Aris Clinic and generalize to larger populations. You had mentioned before the different communities around the Twin Cities, East African, West African, Hmong, and these are communities that we certainly work with. The kids on average as they come in they're struggling with very similar things to one another, regardless of their background. Where there can be challenges, I think Neb, I had mentioned to you a family that I had personally worked with, obviously protecting the specifics about the family, and the daughter had very, very much wanted parents to come in and to get help. There were things happening at home. The daughter was the advocate, a teenage daughter. As we were making contact with the family, Dad came to the first session, but Dad made it clear that his wife would not be meeting with a male therapist alone unless he was there, and did not want his daughter meeting with a male therapist. And you could see right away the challenges of making connection with services or getting some support when you have those kind of cultural things to have to navigate. And if we simply say, well, if we took kind of this Western approach, a woman should be empowered to do right this sort of, that's going nowhere with that family. And so how do we meet families that have different cultural expectations, not just with gender, but about all kinds of things, so that we can work within that culture to try to get them the support that they need within their family and within their culture to go wherever it is that they want to go. I would say those are some of the more challenging things that we face. There's alcoholism in the family, but to be able to talk about that openly, or to get support, or to actually somebody to say, "Yeah, Dad's drinking too much," even though that's always a difficult thing. Well, within certain cultures, that's really not a thing that you come in and talk about, but it's clearly the thing that needs to be talked about. And man, those are challenging things to have to deal with. Even if you're partnering with the right folks and other people within that community, there's no perfect answer to that. And I'm sure a lot of clinicians, not just in the Twin Cities and Washington County, but are having to navigate that.
In my personal experiences, especially with the families and the kids that I work with, a lot of the individuals I work with are immigrants or refugees. The kids were either born in the U.S. or raised in the U.S. There is a cultural difference between parents and the kids, even though we're all we're the same family and everything. It's different when you grew up in America. We have different values, priorities. We grew up in different friends, and also just the values are completely different. What our parents might value might still align with what we value, but it's still different. And I think that with some of the work that I personally do when working with families is just educating them about that specifically, and letting them know that there is going to be struggles, there's a lot of differences. As long as both parties are willing to learn and are open-minded, then we can try to work on those issues. But it becomes a lot more difficult when the older generation is stuck in their own ways and kids are stuck in their own ways and the cultures are clashing. That I see that a lot in the work that I do, in the population that I work with. It's just really hard for parents and kids to sometimes really work together because of that cultural difference. I know that in our culture, religion is a big thing. Um, just the values and the things that we prioritize are completely different. Sometimes your parents might want you to go to college. Maybe that kid does not want to go to college. And it's just a lot of the things that we would normally prioritize sometimes may not align. So I think doing a lot of educational work with parents and the kids together, and just educating them on that cultural differences and how to really come together, work together, and resolve the issues is so important. The other thing that I would add is a lot of, especially like in my community, parents are really afraid of, like, if the kids disclose certain information or certain things that are happening in the home or issues that might be happening. They are afraid of the systems that are in place, like their kids might be taken away by CPS. The police may get involved. Something as simple as, like, obviously domestic violence is not very simple. A lot of kids experience that, but however, even arguments in the home that might get heated, that can absolutely be worked on and resolved in therapy. Sometimes parents are really scared to bring that up, or kids are really scared to bring that up, because parents have conditioned them and told them to not talk about those things because it could open the doors for CPS reports. I've had kids that I worked with who say, this happened, that happened. I wanted to reach out for mental services early on, but my parents specifically told me no, because if you tell a therapist or a mental health provider what happened, they're going to file a CPS report. You're going to be removed from your home. We're not going to see you. There's just this huge fear about the systemic racism and structures that are in place to suppress and affect minority individuals.
One of the questions I wanted to ask you, Sue, in particular, you have been doing advocacy and work and mental health work, at least even within NAMI, over 20 years. And I think, I'm wondering if you can just give a quick example, or like a summary of what are the services that are available in addressing mental health. What is the system, especially on the public side? Because I think sometimes people are not even aware what is out there, and what does that in framework look like today.
I mean, there are a wide range of services. I would say most are covered under Medicaid or Minnesota Care, and less under private insurance. So, under Medicaid and Minnesota Care, I mean, you can get access to, basic therapy and psychiatry, medication management, crisis services. We have, of course, school linked. Then you have day treatment, intensive outpatient, hospitalization, residential treatment, case management. You really have a wide array. Still accessing it, though, can be a problem because of our workforce shortage. We do have mental health parity as a state and federal law, but I will say that it continues to be a dream and not a reality. It was only this past session that we required psychiatric residential treatment facilities to be covered under private insurance. They wouldn't cover it, and yet that's what some kids needed. So it continues to be a struggle. I like to say that our mental health system isn't broken; it was never built, and so we need to keep focusing on what works and really trying to build that out.
Yeah, I think you talked about the system was never built. Talk a little bit about where we started not long ago. How were we treating people with mental illness?
It was institutions and jails. I mean, that was it, right? Our state institutions closed for a reason. They were awful, and nothing against the staff who worked there. They did their best, but people were warehoused. It was not a system. And President Eisenhower actually created the best plan for building a mental health system. And he said that every hospital should have an inpatient psychiatric unit so people don't have to go far from home. You should have in home services, services in the school, outpatient clearly, crisis services. I mean, they laid it all out. And actually, his report also said we had a shortage of child psychiatrists. So, a lot of people listening to this podcast weren't even born when President Eisenhower was president, right? So we've known for a long time what we needed to do. We just haven't had the will or the money to do it. But anyone who says the problem is we closed the institutions has it wrong. The institutions were the problem.
Do we still have state-run hospitals?
So we don't have many state-run facilities anymore. We have what are called community behavioral health hospitals that are 16 beds so that you can use Medicaid. We have Anoka Regional Treatment Center, which has about 100 beds, and then the Minnesota Security Hospital. But they're really for long-term situations, not short-term acute care.
Could you talk a little bit about cultural responsiveness and what it means in terms of reaching those hard to reach populations or to overcome those roadblocks?
Yeah, a big question to unpack, right? Um, I mean, it goes down to there's knowledge, general knowledge, with regard to resources that you can be aware of. For instance, there are community groups that are dedicated to supporting the Somali community or supporting the Hmong community or supporting that are willing to partner with and provide resources, whether it's interpreter services, and we certainly have that here, or who could be a resource, maybe helping a family who's having a hard time coming in to make contact with services. Beyond that, though, of having those kinds of resources, I think it's being aware of maybe some of the shared challenges. We're talking about the immigrant population. I mean, I think of something more recently, fantastic family we had in program not too long ago. Again, I'm protecting some of the details about the family, but had a youngster, a teenager, who was struggling with some things very, very similar to peers in the group who were from different backgrounds. And parents had fled and spent some time in refugee camp, had made it through somehow, kind of war torn civil war. And it was kind of beyond them. I don't understand how you could be struggling. Do you know how great you have it here? Sort of thing. And there was just a clash going on between their kid, who had a Bigfoot, and the sort of normal Western pop culture being a teenager around here, while at the same time participating in some of the culture in the area and region country where they had come from. And it's very complicated to try to untangle. And so I think for our clinicians, we try to take the approach, we don't pretend to assume anything about anybody we're working with, including if you happen to come from or you identify with some a particular group. We can't therefore assume, oh, okay, now we know exactly. We participate in something called Theory of Enchantment that was developed by Chloe Valdry, and one of her first rules is don't treat people as political abstractions. Because you may identify with a particular group, you can't assume to know what might be true about you, whether it has to do with acculturation or cultural practices or making those kinds of assumptions. So it's sort of getting to know each person in each family that comes in. Yes, having some resources available and some knowledge and understanding, cultural humility, and all of that stuff. But you have to learn what might be true about the person sitting right in front of you, and kind of go from there. And That sounds easy, but it's more challenging than you think it is.
I do believe change can happen. I come into every legislative session, believing that we can actually make things better. And I've really seen the attitudes towards mental illnesses change over the last 20 years. Um, but people should not underestimate the power of a personal story. So when legislators hear from their constituents that their child was stuck in the emergency room for a week, or that their loved one was picked up by police and brought to the jail instead of to the hospital, they need to hear those stories. For organizations out there, there is the Mental Health Legislative Network, which is a coalition of over 40 organizations. We work together to create change. So we don't want to have our disagreements in public at the legislature, so we have them at our meetings instead, and really try to come together to push through a ton of bills that will actually help improve the mental health system. But again, vote, contact your legislators, share your story.
I wanted to talk a little bit about children and youth, right? That we know there is a struggle with, just being young and youth and going through life journey, right? But mental health is already on the rise with youth and that are struggling. And what experiences do struggling youth of color experience that might not be addressed or understood that has exacerbated their mental health well-being? And what can we do to address that?
One of the reasons why I started my clinical work back in the day, focusing on trauma, was just due to my own experience and me looking around in the community and trying to answer the question of like, what happened to us? I was thinking of that when I was in undergrad back at the University of Minnesota. Like, something's not quite right here. And my pathway to try to answer that question was through mental health and psychology. And what I learned was, oh, there's this thing called trauma. And I learned it from this man by the name of Sam Simmons. He may be a good person to reach out um, to be a podcast guest in the future. But he was the first person who labeled it for me. Like, I was feeling it, I was seeing it, I was experiencing it. And then he gave me the term trauma. And it was just like somebody just took a veil off my head. And it was just like, here it is. This is the thing you're seeing and you're dealing with. And I started to connect these dots. And then I learned about, okay, there's family patterns here. And then I went to school, became a marriage and family therapist. And it just all was making sense, whether I was looking at my own life, my friends, some of my peers, or even just looking at case studies. A lot of it dealt with just family patterns and histories of what was going on. And then from there, I learned about adverse childhood experiences and what takes place when the young person goes through adversity, how that can impact their social and their mental and physical health later on in life. And that's really what kicked off my work, was just helping people understand what those things are, how they play a role. And now in the phase of my life that I'm in, I'm really looking at this thing called post-traumatic growth, which is what can you do about it? Now that you know about the trauma that you've experienced, or the community trauma that may be happening, what can we do to keep living in a life where we can thrive, be as mentally healthy and well as possible, and make sure we're supporting each other in community? And that's where a lot of the work that myself is doing, the same with my organization MACMA, is really helping folks move forward if they can to the best of their ability.
I think Brendan said it really well. The only thing that I would like to add is sometimes just trying to go above and beyond to kind of, really get the services they need in place. I've worked with individuals in the past where I had to go find services for them. For example, I'm not a psychologist, so I don't do psych testing. There are a lot of psychologists in private practice, calling a private practice agency and referring a client out, but they don't have interpreters. They're not willing to put in the work to go find an interpreter. There's no one to take that extra step to call insurances and find maybe like in network, what is it called, interpreters that can either come to the appointment, join through phone. I think just being really mindful that when you're in this field, sometimes people have to do the extra work and take that extra step and really make the services you're offering accessible for people. And just really, really doing that, making sure that, if someone is coming to you and you understand that there's a language barrier, not having a family member interpret for them and getting a professional interpreter to do that work.
Absolutely. Yeah. Those are our two biggest focuses, is making sure parents and caregivers get access to information. We do that through a lot of different ways, whether it's written, we do our own podcasts. We have, we're creating videos. We just want to make sure people have as much access to information as they can. and then also working with the folks who do the work, and how do we connect those two groups together. Sometimes we look at educators and mental health professionals as community members, as people who are too busy, they don't understand what's going on with my family, etc. And then on the other end, professionals look at families the same way. So how do we mirror match those two together is one of the things that we try to do as an organization.
Sounds good. And then, Sue, I think my question for you is just since advocacy and legislature work in drafting legislations and educating legislatures is a big part of your work, what have been the highlights of some of the recent legislative efforts in addressing access to care in mental health and also in health equity?
I'm glad to say we have made some progress. It's still a long way to go, but we have made some progress. One of the things we see is our workforce is largely white, and we saw a lot of people who graduated but actually didn't get their license. And one of the things we heard is that they couldn't find a supervisor from their race or culture. And so we did pass legislation that actually funded BIPOC mental health professionals to become supervisors. So over 200 have now become supervisors, and that money is continuing to grow. So we think that's a good thing. There is the CMIG grant, Cultural Ethnic Minority Infrastructure Grant, that was getting about $600,000 a year, and now it's going to $3 million a year. And that really helps build up the infrastructure of culturally specific organizations, but also helps in terms of workforce by providing supervision for free. And some of that money can actually now be used for interpreters in residential facilities to make sure that there's better access to that level of care. There is some funding for cultural healing. We need to keep expanding that because I think it's an important part of our system. And then the other thing that might seem a little weird is the diagnostic assessment, so that you no longer have to do a full blown one practically at the first or second visit, that can actually wait for almost a year so that you can actually, get to know the person and not ask these really personal questions right off the bat. The last thing I'll say is that one of the frustrations I think that many of us feel is that we'll get calls from families and they'll say, I know my loved one, the symptoms are coming back, but they won't go to treatment voluntarily. If they call the county says, well, until they're a danger to themselves or others, there's nothing we can do. And so we did pass legislation 3 years ago. It finally got funded this session for what we're calling voluntary engagement. So you could send out a peer specialist who could connect with that person, come back every day for 90 days to try to engage them in treatment voluntarily. We think about it like a homeless outreach worker. They don't get someone into housing the first day that they talk to them, right? But maybe after a week or 2 weeks or 3 weeks, they're able to get them into housing. And that's what we wanted to do here too. So kind of that early intervention, preventing interactions with police, with the emergency room, all of those kinds of things. So a lot goes on at the Capitol, and I will say that a lot of it is based on the personal stories that we hear.
I'm really glad to see some legislations that are advanced in the field because one of the things I've been living in Minnesota for 20 years, and one of the things I used to hear is how the reimbursement is low for mental health providers, so they cannot attract mental health professionals to come and work for them. The field to become a clinical supervisor or clinical worker is long. So a lot of the problems that you've mentioned is kind of what was a turn off to get more people be interested in the field. And now I think these things are going to just remove a little bit of the barriers. But I'm sure there's more that needs to be done. Obviously, that's not enough. We still need more people coming in the field, and we need to make education more accessible and probably remove some of the paperwork that families have to do just to even get access to healthcare or to therapy and whatnot. So I think, but it's a first, I think it's a good start.
I will just say the rates are still too low. So that hasn't been fixed. It got a 3% increase this last session, but we need to do a whole lot more work there. The one thing I forgot to mention is that for the first time, we actually require continuing education on becoming culturally informed and responsive for all the mental health professionals, which also was a big move because frankly, many of the boards were opposed to putting a certain number of credits there. I think we got it to 4. We had started at 8, but that was also, I think, an important move forward.
Well, I want to thank you for engaging this conversation with us. We want to thank you for your time. And I think our goal is to be able to communicate with stakeholders in these important issues. And I feel like there was a little bit of a nugget for everyone listening, whether they're parents or youth or legislatures or policymakers. And I just want to thank you for sharing your perspective and your experience and your stories. I know they will change lives, and I thank you for that.
Thank you, Anya. I appreciate it.
Awesome. Thank you.
Thanks for inviting us.
If you are or you know of anyone facing mental health struggles, emotional distress, alcohol or drug use concerns, you can call, chat, or text 988 to reach the Suicide and Crisis Lifeline. It's free and confidential, with 24/7 support from trained providers. Washington County residents can call their crisis response unit. They provide mobile crisis mental health services for adults and children experiencing crises. These interventions can be over the phone or face-to-face with trained mental health service providers. Washington County Crisis Response Unit is available 24/7, 365 days a year, and can be reached at 651-275-7400. Interpreter service is available and services are free and confidential. Policy Connecting Communities is produced by AG Consulting and Media. The Policy Connecting Communities podcast, produced by AG Consulting and Media, highlights the public health efforts and strategies used to empower and grow community and policy development. This program is being supported in part by the federal award number SLFR-P0312, awarded to Washington County by the U.S. Department of the Treasury.